to die from breast cancer than white women. And we're also more likely, unfortunately, to develop a very aggressive form of breast cancer called triple-negative breast cancer, which is more deadly than another form of breast cancer that usually affects white women. Not having children, so never having a pregnancy, or having children later on in life, so after the age of 30, is a strong risk factor for breast cancer now. Unfortunately, sometimes we cannot really prevent this. You know, a lot of people now are going to school, university, and so they're delaying starting a family, and unfortunately, that puts a woman at a higher risk of developing breast cancer. The higher number of menstrual periods a woman has also increases the risk of breast cancer. And how will a woman have more menstrual periods throughout her lifetime? That's by starting the periods early, which is not something you can control. So starting one's period before the age of 11 or 12, or going through menopause later in life after the age of 55. So you have more time in your life to have menses, and that puts you at risk for breast cancer as well. Breast density is also a risk factor for breast cancer. Breast density is not really what you feel, but it's something that is read on a mammogram. If you ever have a mammogram, you might have seen on the report that the breast is very, very dense. And unfortunately, black women have denser breasts than white women. And so because of that, we're also at a higher risk of developing breast cancers. Breastfeeding. Not breastfeeding has been shown to be linked to the very aggressive form of breast cancer that black women have, called triple-negative breast cancer. And so what we've seen is that breastfeeding multiple children for as long as you can, particularly greater than 1 year, is actually protective against triple-negative breast cancer, again, which preferentially affects black women. Physical activity, being sedentary, not being active, increases the risk of breast cancer. Being overweight, obesity, that also increases the risk of breast cancer, particularly breast cancer developing after menopause. Alcohol use is also a risk factor that has been proven recently, and the risk for breast cancer goes up as the more you drink. And so what they found is that a glass of wine is 5 ounces, and drinking a glass of wine every day increases the risk of breast cancer by about 2 to 3 times. And 1 glass of wine, I think, is equal to about 1 bottle of beer. So all women can lower their risk of developing breast cancer. So what are some of the things that we can do? You can get to and stay at a healthy weight by exercising. And remember, your weight is controlled by 3 things, actually. I was going to say 2, but it's 3 things. 1 is your intake. Your intake is actually it is responsible for 80 to 90% of your weight. Physical activity is responsible for only 10 to 20% of your weight. So if you're exercising, every day of the week, 5 hours a day, and you're still eating what you shouldn't eat, you're going to remain obese. And then, of course, the last thing is genetics. So being physically active, what is recommended is 150 minutes of moderate intensity activity or 75 minutes of vigorous intense activity. So moderate intensity activity is like a brisk walk, and that should be broken up. So the 150 minutes is spread throughout the week. It's not recommended that you bunch it all in 1 or 2 days, but rather you spread it out through multiple days. And then vigorous activity is anything that makes you sweat, like running on the treadmill or jogging. And then, of course, limiting or avoiding alcohol use is also key in lowering one's risk of breast cancer. Like I said, breastfeeding, if you breastfeed, you are protected against the aggressive triple-negative breast cancer that preferentially affects black women, and also not using hormone replacement therapy to combat the symptoms of menopause is key in lowering your risk of breast cancer. Now, there's some women who are at particularly higher risk than the general population, and these are women such as Angelina Jolie, who have the known mutation in one of the genes that causes breast cancer. That's called the BRCA1 or BRCA2 genes. And there are also some other individuals who are at a very high risk who are not known to have genetic mutations. These are people that have a very extensive family history of breast or ovarian cancer in multiple first and second degree relatives. You might know some people who have many of their sisters, their mother, their grandmother, their cousins having breast cancer. For such very high-risk women, there are some medications that can actually be given called chemopreventive medications to reduce their risk of developing breast cancer. And also, if you are at a very, very high risk, sometimes we do recommend that patients undergo prophylactic, so that's preventive bilateral mastectomies, removing their breasts. And this can lower the risk by about 98%. That risk doesn't go to zero because there's always a little bit of breast tissue that's still on the chest wall that can never be taken off completely. And then also, if people have completed childbearing and they're at a very high risk, they can consider removing their ovaries because the ovaries are not being used anyway. That can lower the risk by about 50% even if you don't remove your breasts. So, like I said, there's absolutely no sure way of preventing breast cancer, but there are things that all women can do that might reduce their risk of developing breast cancer. And there are also some strategies that we can do that might increase the chance that if you do develop breast cancer, it's detected very, very early when it's most curable. And so this brings me to screening. So why do we screen for diseases? We screen for diseases that are common, where we know that we can make an impact. So like I said, breast cancer is very, very common all over the world. 1 in 8 women will get breast cancer. And so we screen for breast cancer because you would have to screen 8 women to save 1, which is cost effective. We don't screen for diseases that are very rare because it's not cost effective. For instance, brain cancer is very, very rare. It happens, less than 1 in 1,000. So in that situation, you would have to screen 1,000 people to pick up 1. So there's no screening for such a disease. The other reason why we screen for breast cancer is that it can be very deadly. In women, it's the second leading cause of cancer-related deaths, second only to lung cancer. And then, of course, we know that if breast cancer is detected early, because it's still contained in the breast, and the breast is not a life-sustaining organ, it can be fully cured. So these are the most recent updated screening guidelines from the American Cancer Society, which essentially is the body that the whole world follows. And previous to their new recommendations, the blanket recommendation was that all women should start screening mammograms once they hit the age of 40. And so right now they've changed those recommendations to 45 to 54. Women should get screening mammograms once a year. And over the age of 55 and beyond, the mammograms should be done every other year until as long as a woman is in good health. For instance, if a woman is 70 years old and she has multiple comorbidities, multiple other medical problems like diabetes, hypertension, she's had a stroke, she's in a wheelchair, it doesn't make sense to screen for breast cancer because there are other more serious diseases that are competing for her life. So as long as the woman is in good health, the screening will continue. Once the health of a woman is failing and there are other more serious diseases, screening stops. There's also a clause in there that you can still start screening mammograms at the age of 40 if you so desire. And so what we're recommending is that all women should start screening mammograms once they hit the age of 40. So clinical breast examination is the second way, and this is something that is particularly relevant to our community because this is a low to middle income setting, and screening mammograms are not available for everybody because of the cost and availability. So there's currently research that is going on to determine if clinical breast examination can be a low-cost option for this kind of environment. The results are not available yet, but the preliminary results show that those people who are in the screened group, screening with clinical breast examination, present with less advanced cancers than those women who are unscreened. And so what is a clinical breast examination? This is when a medical professional, a nurse, a paraprofessional, or a doctor administers a physical examination on a woman's breast to detect any abnormalities. And the recommended schedule is every 3 years for women in their 20s and 30s, and once a year for women in their 40s. And so if you're going to your family doctor, your family physician, practitioner for anything, ask them to do a clinical breast examination on you just to check around the breast. The third modality is breast self-examination. So I've actually listed this as breast self-awareness because we don't call it breast self-examination anymore, because research has shown that it really doesn't impact the clinical outcome of patients with breast cancer. It doesn't really change mortality. But what it does is that it actually empowers women to take responsibility for their own health, so that so that all women in general should know how their breasts feel, so that if there's a change, you can bring this to medical attention. So it's not really used as a screening tool anymore, but more for raising awareness. And so what we recommend is that you feel around your breasts once a month. You pick the same time every month, maybe the first of the month, the middle or the last. Just kind of feel around the breast so that you know exactly what your breasts feel like, so that if there's a change, you can know that this is not normal for you. You can now bring that to medical attention. And I'll go into a little bit more detail about clinical breast examination and self-breast awareness in a little bit. So what is a mammogram? This is the recommended tool to screen the average woman, the population, for breast cancer. So a mammogram basically is a special X-ray of the breast. So what happens is that there are two plates here. So this is the machine, and there's a plate underneath and a plate on top, and the breast is kind of pulled into that into the bottom plate and spread, and then it's compressed. It's not painful, it's just a little bit uncomfortable. It takes probably less than 10 minutes. Once the breast is compressed between those two flat plates, the picture is taken and sent to the radiologist, and that picture on the spread out breast, the radiologist can see any abnormalities in the breast. And this is the picture of what the mammogram looks on imaging once it's all spread out. So sometimes we consider breast MRI for patients, again, who are at a very high risk, say for those patients who have multiple family members with breast ovarian cancer, or perhaps are known to have one of the mutated genes. And so what we recommend is that it's not in place of a yearly mammogram, but it's in addition. And so we recommend both an MRI and a mammogram either once a year, or one of the strategies every 6 months, to keep a very close eye on the woman. And so an MRI scan, instead of using conventional X-rays that a mammogram uses, it uses magnets and radio waves to make more detailed cross-sectional pictures of the entire breast. The problem with MRI and why it's not recommended for everyone is because of three things. Number one, it's expensive. Number two, it can require contrast to be injected into the woman so that they see the pictures better. And then number three, it's very, very sensitive. So what it does is that it can find a lot of things in the breast that end up not being cancer. And so what we've seen with women getting MRIs is that more often than mammograms, those women are called back for abnormalities on their MRIs, and they end up needing more unnecessary biopsies for things that turn out not to be cancer. So that's what we call recalls and unnecessary biopsies. That's the reason that MRIs are not done for everyone. So again, a clinical breast examination, like I mentioned, is an examination of your breast by a healthcare professional. And this is just a picture of, how it's done. So you lie down and basically somebody just feels around, feels the breast, feels the armpit, make sure everything feels normal. And this is what can be picked up by a trained clinician. A trained clinician can pick up a mass of less than 1 centimeter, even down to 0.5 centimeter, while somebody that is untrained, you know, if you're not trained, a patient can probably pick up a lump that is probably about 2 centimeters. So that's why we recommend clinical breast examination, because they can pick up tumors that are much smaller than you can pick up yourself.